Morning. Good morning, everyone. So today, actually, we had planned a lecture on bariatric surgery by Dr. Mahendra Narwaria, who is at Ahmedabad, the Asian Bariatrics. He actually is in Jaipur for some social visit, and he had very kindly agreed. But there is some problem with his laptop internet connectivity at the hotel where he is staying, and that place is very far from our institution. So it's not possible for him to come. So I don't think it will be possible, although we are trying whether he can connect through his phone. So what we will do, we will just have an open house discussion on any topic. So I can see three students there, Rohan, Venkat, and Yogen. Maybe you can put your camera and microphone on. So what was the case? We can have a just a discussion. What case was it?
Sir, it was basically a 66-year-old female who presented in the in SDMH hospital with the main complaint of increased RT aspirate. She has been on RT feed from past 12 months. Had a left MCA infarct with aphasia around 12 months back. Post which she was on RT feed, and she was doing well till approximately 10 days back, but then she started having increased RT aspirates and had several bouts of vomiting, black colored initially, which gradually turned into gastric colored, and that was the case. And she's a known hypertensive, vegetarian by diet, and no other prominent surgical history was present as such. So that was the case, which was on evaluation was found to have a in the background of a large hiatal paraesophageal hernia. It was
No, let's stop at that. So, an elderly lady with some intracranial problem, is it?
yes,
And on rice tube feeding.
yes, sir.
So, what is the indication for rice tube feeding in these cases? Why a rice tube is put for feeding?
Sir, most of the neurogenic conditions, as what I have read, leads to problem with the swallowing and causes what we actually call as cervical dysphagia. So that would have been the reason, because initially the patient was being managed in the neurology department. So they usually put rice
So,
tube to
this
feed.
is functional oropharyngeal dysphagia.
Yes, sir.
Usually, they have problem in swallowing.
Yes, sir.
And what is the problem? What happens when they try to swallow? These
Uh,
patients with neurological disorders.
Sir, either the swallowing becomes very slow, so the amount of food that they can take in go decreases, which in on a long term basis might lead to I would say loss of weight. And the other eminent problem is the presence of the I mean, like the respiratory complications of aspiration is one of the most prominent reasons.
So that's more important that they, because there is dysfunction of swallowing process, they tend to have recurrent or repeated aspiration. And that is the reason why we do not allow them to take orally and we place a feeding tube.
Yes,
Okay. So
yes,
functional oropharyngeal dysphagia, the problem is aspiration.
yes.
Same thing can happen if you have a very high mechanical obstruction. Suppose you have a stricture in the cervical esophagus or growth in the cervical esophagus. These patients are more likely to aspirate as compared to a patient who has a stricture or a growth in the thoracic or at the GE junction.
Yes, sir.
And the other group which is likely to aspirate is the other functional disorders like achalasia, where over a period of time the esophagus dilates, it gets filled with fluid, saliva, food residue, and then, especially at night time when the patient is supine, there is regurgitation. It is not vomiting, it is regurgitation of this food and fluid, and they can aspirate. So that is as far as neurological oropharyngeal dysphagia is concerned. But suppose the neurologist says that this patient is not going to regain the oral swallowing process what is the ideal treatment? Is Rice tube the ideal treatment?
Sir, Riles tube actually in long term also causes reflux. I mean, the reflux is do associated with the Riles tube. So either we have to, if we are planning for a enteral feed, there are mechanisms that if we either we can go on a long term PEG tube, or we can plan for a FJ feed, or if it is because of the like in this case, if it is in the view of the large paraesophageal hernia that has been found as.
We don't know that it is paraesophageal hernia. We are only talking of neurological oropharyngeal. You will get a consultation from your neurology colleagues that this patient cannot swallow. He or she is aspirating, and I don't think this function is going to change. So I want a permanent feeding port. What feeding port would you advise?
Sir, we will I plan for a PEG tube, sir.
What tube feeding?
Polyethylene gastrostomy tube, percutaneous endoscopic gastrostomy tube. Sorry,
Yeah, so say percutaneous.
percutaneous.
Gastrostomy can be surgical also.
Yes, sir.
So
Percutaneous.
the ideal treatment of long-standing or likely to be permanent neurological oropharyngeal dysphagia is a percutaneous endoscopic gastrostomy, because there is no mechanical obstruction. The scope will go easily, and it is a procedure which can be done without general anesthesia. It is a procedure which can be done as a even as a bedside procedure. Some of these patients may not be fit for general anesthesia because of their neurological condition. So
Yes, sir.
the ideal treatment is a percutaneous endoscopic gastrostomy. Do you know how is it done?
Sir, I have never I'm assisted in one. It's being done in by the gastroenterology department. So, I'm sorry for
Describe how it is done.
that. Sir, I have never assisted one actually, so sorry on that point.
Yeah, so I may not be able to give you all the exact details, but basically you put in a scope, you distend the stomach with air. So once the stomach is fully distended, the anterior wall of the stomach comes in approximation with the parietes. And then you puncture with a needle. And through that needle, there is a guide wire, and over the guide wire, the tube is placed. That is the basic principle. But I think all surgical students should go and see at least one percutaneous endoscopic gastrostomy. I'm sure this must be done by your endoscopist, and see how it is done. Okay, so that is, and as far as feeding ports are concerned, the best feeding port is a gastrostomy. Why is gastrostomy better than a rice tube? Rice tube also is delivering food in the stomach. Gastrostomy also is delivering in the stomach. So why do you want a gastrostomy?
Sir, first of all, it is more discomforting for the patient carrying a riles tube for a very prominent time. Number one, then it is that patients taking out inadvertent removal of the riles tube is the second important point, which is a probable source of trauma to the in the nasal area. So these are the two reasons.
Suppose the
Second,
patient is, suppose I say the patient is unconscious. So discomfort doesn't matter.
yes, sir.
ये तो मतलब हमारा वो पार्ट में नहीं रहता है।
So what is the advantage of a gastrostomy over rice tube? You did mention something in earlier. It is that the rice tube makes the GE junction incompetent. Any valve, if there is a tube across it, becomes incompetent. That is why when you place a stent in the biliary tree, you run the risk of having cholangitis, because then the papilla becomes incompetent, the papillary sphincter. There can be a reflux of the duodenal contents. Of course, the stent itself can cause cholangitis as a foreign body. Similarly, when you have a rice tube across the GE junction doesn't remain competent. It develops some incompetence, and there will be reflux, which will not be there if you have a gastrostomy. So that is the advantage of a gastrostomy over rice tube. And obviously, the discomfort and inconvenience is there. As far as removal is concerned, even gastrostomy can get accidentally removed. Any tube can get accidentally removed. Why not jejunostomy?
Sir, actually, bolus feeding with the jejunostomy will be, uh, cannot be done. We have to give on a continuous feed with the FG feed. That is one of the reasons, I believe.
Yeah, but that's not the most important. Most important is that gastrostomy obviously is more physiological than jejunostomy, because when you are giving feed in the stomach, in the duodenum, the mixing of the food and the bile and pancreatic juice and the enteric secretions is as it happens normally. Whereas when you are giving jejunostomy, because you will make jejunostomy a few centimeters from the DJ, so the mixing of the food with the enzymatic secretions is not physiological. So whenever you have a choice, gastrostomy is always preferred over a jejunostomy. Now let's discuss this case. So you said that she has been on rice tube feeding for 1 year
Yes, sir.
and she was tolerating it.
Yes, sir.
And now she is having vomiting.
Yes, sir.
What is the nature of vomitus?
Sir, initially, actually, the patient is aphasic. So the history was given by her son, who is taking care of the patient. So he said that it was around 10 to 12 days back. It was initially, it was 2, 3 bouts of black colored vomitus, which came out approximately 100 to 150 ml. And then the color changed to the more towards the gastric content. As and when the patient was examined, it was more of, the gastric colored content, sir, non-bilious.
So why do you think that now she has developed vomiting? She was tolerating the feed. What could
Sir,
be the possible cause?
Sir, it might be that first of all that she was as the RT was present across the GE junction for a very long time. The reflux might have caused esophagitis, or it might have also caused erosions in the gastric fundus. That might be the reason of chronic blood loss, which has led to this for initial. Uh, Brown colored vomitus present. And the another reason can be that if in these cases, in long term cases of large paraesophageal hernias, the chances of formation of a gastric volvulus are also very high. So that might be a reason which might have led to sudden increase in RTS spirit, as well as the vomiting episodes.
So you said reflux will cause erosions in the fundus of the stomach. Is that true?
Is in the GE in and around the GE junction, sir.
It will be reflux esophagitis. There is nothing called reflux gastritis unless you are talking of bile reflux. Reflux of bile can cause gastritis, but acid will not cause gastritis in the stomach because stomach is used to presence of acid. Reflux of acid or gastric contents causes reflux esophagitis. So agreed, that explains the possible blood-stained vomitus, the black vomitus. But and this paraesophageal hernia, was it known at that time or it is a new finding?
Sir, there was an endoscopy which was done, which was suggestive of a small hiatal hernia. Approximately, I think it was done in the month of October, I believe. So it
At
was
the
known.
time of placement of the rice tube?
No, it was done afterwards, because there was a small incident in the past also, when there was a cessation, when the RTS spirit got increased. So they had got a endoscopy done from the neurology side itself. So it was there.
So what do you mean by hiatus hernia?
So, hiatus hernia is a terminology which denotes that due to the weakening of the diaphragmatic hiatus, the contents of the abdomen start moving inside the chest, which in further classification has been divided into 4 types.
Yeah, so it's hernia. Normally, you have a small length of even esophagus in the abdomen below the esophageal hiatus, about 2 centimeter, 3 centimeter, 4 centimeter, depending on the build of the patient. But there is an intra-abdominal length of the esophagus also. So the G junction is not at the hiatus. G junction is below the hiatus or caudal to the hiatus.
जी sir.
And if any part of the stomach herniates into the chest through the diaphragmatic hiatus, esophageal hiatus, that is what is called hiatus hernia. And what are the types?
Sir, type 1, which is the most common type, is known as the sliding hernia, in which the G junction itself moves inside the thorax in the posterior mediastinum. But the anatomical level is still the anatomical position in comparison to the fundus is still the same as in the normal anatomy. Type 2, from type 2, type 3, and type 4 are all known as the paraesophageal hernia. Type 2 is the case in which the fundus moves into the thorax, but the G junction remains in the intra-abdominal. Type 3 is a mixture, which is the most common one amongst the type 3, type 2, type 3, type 4. It is the one in which both the GE junction as well as the fundus of the stomach moves into the thorax. Type 4 is the condition in which we do find other structures apart from stomach, like small bowel, mesentery, transverse colon inside the thorax.
Yeah. So in the sliding hernia, it is the G junction which moves up. So G junction, which normally should lie in the abdomen below the hiatus, now comes to lie above the hiatus in the chest.
Yes, sir.
That is what is sliding hernia. Whereas in paraesophageal hernia, the G junction remains at its normal position, and it is usually the fundus of the stomach which herniates through the enlarged hiatus or weak hiatus into the chest. And the other ones, as you mentioned, type 3 and type 4 combination, and other viscous. Other viscera, you mentioned small bowel, but which is the other next common viscous which is present in a this hiatus hernia other
Sir,
than the
transverse
stomach?
colon. I believe, sir, transverse colon.
Yeah, it's the spleen or transverse colon. Small bowel comes later, much later in large hernias. Usually it is the colon or the spleen. So out of these two, paraesophageal and sliding, suppose how do you diagnose whether it is hiatus hernia number one and then which type it is?
Sir, initially, in going by the epidemiology, the most common one has been found to be the sliding one in type 1 type, which is 95%. And for the diagnosis, we can have the chest X-ray in PA view. Apart from that, we can have a barium swallow or barium upper GI series, which will help us to confirm the diagnosis. And for further evaluation, we can use the other radiological investigations which are present. Also, endoscopy is to be done, but it is for the diagnosis purpose. I would say it is barium swallow esophagogram. That's what.
Which is the best investigation to diagnose hiatus hernia?
Sir, barium esophagogram is the gold standard because it is easily available, and it also.
Sorry, say again.
Sir, barium swallow, that is barium esophagogram or barium upper GI series.
I'm not sure whether barium would be the best investigation. I ask you which is the best investigation. I suppose it would be CT, because CT will show you the exact location of the G junction, the hiatus. Okay, let's discuss one by one. How do you diagnose hiatus hernia on barium?
Sir, sir, we will get a picture in which we can comment upon the intra-abdominal length of the shortened intra-abdominal length moving of the GE junction upwards. That's
so. The definition of sliding hernia, as you said, is that the G junction comes to lie above the esophageal hiatus. Will you be able to see the esophageal hiatus on a barium meal?
No, sir, it will not be seen, but from the anatomical position from counting by the vertebra.
So unless you see the diaphragm, because then
Yes,
you imagine that the hiatus is in the diaphragm, and then you see the relationship of the GE junction to the diaphragm. Same way, paraesophageal hernia, unless you see the soft tissue shadow of the diaphragm, you will not be able to see whether any part of the fundus is above the
yes, sir.
diaphragm or not, isn't
Yes,
it?
sir.
That
Yes,
is
sir.
why, but check again. I am not 100% sure, but I probably think that CT is a better or the best investigation. Okay, you said endoscopy. How do you diagnose sliding hiatus hernia on endoscopy? Because you are looking only at inside.
Sir, we do have a special retroflexion maneuver, or the J maneuver, that the retroflexion maneuver to for the which assists in diagnosis of hiatal hernia.
So, what do you see when you retroflex or do the J maneuver of the scope?
Sir, we will be seeing two lumens. I mean, in the above the esophageal hiatus, we will be seeing two lumens in the
How would you
retroflexion.
see the hiatus? The scope is inside. You are only looking at the mucosa. That is the disadvantage of. See, the barium shows you the lumen. Endoscopy shows you the mucosa only. So you are looking only at the mucosa. How do you know where is the hiatus on endoscopy? How do you identify the G junction on endoscopy?
Sir, it is the I mean, the transition zone is being identified, and then which helps in identifying the
So
G.
what is the transition from this to that? What change do you see?
Sir, we'll be shifting from stratified to columnar, I believe.
Those are histological findings. On endoscopy, you can't say whether it is squamous or columnar. What landmark endoscopists mention? What is the word or
The
phrase they use?
Sir, Schatzgering or the Z ring, I mean,
Z line, isn't
Z
it?
line.
Z line, I think it is by color. The color of the squamous mucosa is different from the color of the columnar mucosa. Again, check with your gastroenterology colleagues how exactly they do it, but that is the Z line. So that is what signifies the G junction. Also, there is a change from a tubular structure to a balloon-like structure. That is again is the G junction. But is there a condition where these two may not correlate with each other? That the change from tubular to balloon is at some other level, and change from squamous to columnar is at some other level? What is that condition? So, in other words, what is the condition where even the tubular esophagus is lined by columnar epithelium?
Sir, the formation of the Barrett's
Barrett's.
changes.
So if you see that you are still in the tube, but there is a change in color from squamous to columnar, that indicates that the lower part of the esophagus is now covered by columnar epithelium, and that is what is known as Barrett's. Now, coming back to the esophageal hiatus. So, when you are doing an endoscopy, the endoscopist can appreciate what they describe as a diaphragmatic pinch. When the patient takes a breath, there is a pinch of the tubular structure on the scope, which is the position of the esophageal hiatus. That is what they describe as the diaphragmatic pinch. Now, if that diaphragmatic pinch is lower and the GE junction is above that pinch, that means that there is a slide.
Yes, sir.
Sliding hernia, what is the definition? Definition is that the GE junction is above or cranial to the hiatus. So they can see the GE junction on endoscopy and they can identify the diaphragmatic pinch. That is how on endoscopy they diagnose a sliding hernia. But on endoscopy, they will not be able to diagnose a paraesophageal hernia because even if you do retroflexion, you are only seeing the fundus. But you don't know whether this fundus is below the diaphragm or above the diaphragm because on endoscopy, you don't see the diaphragm, isn't it? So,
Yes.
paraesophageal hernia, you are right, is better diagnosed by barium if you see the soft tissue or diaphragm. And I thought it is the CT where you can see everything. You can see inside, you can see lumen, you can see where G junction is, you can see where esophageal hiatus is. Okay?
Yes, sir.
Fine. Is there any condition which you can mistake as paraesophageal hernia, and it could be something else, which can look like a paraesophageal hernia, a condition of the diaphragm.
Sir, the diaphragmatic hernia, the eventration of the diaphragm or
Eventration. So, what is the difference between eventration and a diaphragmatic hernia? Esophageal hiatus hernia is one of the types of diaphragmatic
diaphragmatic
hernia, isn't it? There are so many other types of diaphragmatic hernia, the Bogdalek and Morgagni and others. So on a especially on a plain X-ray, when you do a chest X-ray, you see an elevated dome of diaphragm. It could be a eventration or it could be a large paraesophageal hernia or diaphragmatic hernia. So, what is the difference between the two? What is eventration?
Sir, eventration is the muscular laxity of the diaphragm, which leads to severe elevation seen in the radiological pictures. While actual diaphragmatic hernia is when the content of the intra-abdominal content would start moving across the will across the diaphragm. Actually, the content will never cross in diaphragmatic eventration into the thorax. It will
Eventration is a weak diaphragm or a paralyzed diaphragm. It could be either congenital or traumatic.
traumatic.
And the on a plain X-ray, the contents appear to be in the chest, but technically speaking, they are still below the diaphragm, which is elevated, and they are in the abdomen.
Yes,
on the other hand, diaphragmatic hernia is a defect in the diaphragm, either a normal defect like esophageal hiatus or an abnormal defect like in the dome of diaphragm, the true diaphragmatic hernia, through which the abdominal contents go across the diaphragm into the thoracic cavity. Okay, coming back to the hiatus hernia. So there are three terms. One is hiatus hernia. Another is reflux esophagitis. What is reflux esophagitis?
Sir, reflux esophagitis is in view of the constant acid reflux. There occurs linear mucosal erosions in the GE junction and in the lower end of esophagus, which is known as reflux.
So, in which hernia esophagitis is going to be present?
Sir,
which type?
Sir, mostly it will be with the sliding type only, because the GE junction is moving, and GERD is has been associated with
So
the
it is characteristic of sliding hernia, because that is where the GE junction has moved up into the chest and there is negative pressure in the chest. In the abdomen, there is positive pressure.
positive.
In the chest, it is negative pressure. It can be there in a paraesophageal hernia also, because the GE junction sphincter is actually not a true sphincter. It is a combination of factors, and one of the factors is the diaphragm. So in a paraesophageal hernia, the diaphragmatic esophageal hiatus is wide. So that part of the sphincter is not there. So still there could the esophagitis doesn't occur in the fundus, in the herniated part. It occurs in the normal esophagus because of the lax diaphragmatic hiatus. But because the G junction is still inside the abdomen, the chances that there will be esophagitis are less. Okay. How do you diagnose that there is reflux?
Sir, in starting from the patient symptomatology, patient will complain of
No. Specific. How do you demonstrate that there is reflux of acid into the esophagus? What is the
D-Mister score is being calculated, which comes if more than 14 is diagnosed for GERD.
Sorry, say again.
Sir, D-Mister score is being calculated, which if it is more than 14 is typical of GERD.
The test for demonstrating reflux is 24-hour pH monitoring.
pH monitoring,
okay?
Sir. Yes, sir.
So for how much time the acid, the pH of the esophagus is less than a certain limit, again check what is the exact number. That is what shows. So you diagnose esophagitis on endoscopy. Esophagitis means endoscopic changes of inflammation in the esophageal mucosa. You diagnose reflux by 24-hour pH monitoring. And you diagnose hiatus hernia by one of the radiological studies, either barium or a CT scan. So they are usually associated with each other, but not necessary. The patient may have a sliding hernia, but no esophagitis. The patient may have esophagitis, but no hernia. And the third term, which you yourself mentioned, is GERD. What is GERD?
Sir, gastroesophageal reflux disease leading to changes in the esophageal mucosa due to persistent exposure to of the acid, that is GERD.
Yeah, so GERD is the clinical entity. It is a combination of symptoms, which include retrosternal burning,
acid rash,
heartburn,
laryngitis,
acid irritations, and then if it is severe, it can even present like sore throat. It can cause otitis media when the irritation comes up to the eustachian tube. It can even present as bronchospasm because many of these patients
COPD
are
changes.
misdiagnosed as bronchial asthma or COPD. They can be diagnosed as otitis media. They can be diagnosed as rhinosinusitis. But the classical presentation is retrosternal burning and pain. So, hiatus hernia, acid reflux, esophagitis, and GERD, they are usually in combination, but it is possible that one is present and other is not present. And these are very specific terms. Okay? Fine. So, what is the treatment of reflux esophagitis or GERD?
Sir, reflux in the treatment starts the very treatment starts with the changing the lifestyle habits of changing the kind of meals the patient is taking, along with the amount of number of meals has to be increased, and the last supper and the sleeping time should have an interval of approximately 2 hours. And then non-specific procedures like elevating the head end of the bed, and all of this has been tried. But the pharmacology, coming on to the pharmacological, we have proton pump inhibitors.
Any other lifestyle change important?
Sir, also, if the patient is obese, which is in GERD patients, which is one of the which is in nowadays a more common finding. So lifestyle changes to reduce the weight is also smoking, increase less intake of caffeine and spices. All of these are some of the changes.
Even weight reduction, avoiding stooping, avoiding bending down, all these maneuvers do increase the episodes of reflux. Every time you bend down, there is some reflux. And every time there is reflux, it will cause more esophagitis. So all these instructions are very important along with pharmacological management.
Yes, sir.
What is pharmacological management of reflux esophagitis?
Sir, proton pump inhibitors is being the major cornerstay of the management for the GERD, sir.
That's all? Nothing else?
I mean, I have not gone through the latest, the treatment, so I won't be able to.
Usually, PPIs are combined with something. They are actually available as fixed drug combinations also.
Sir, H. pylori is one of the.
No. I mean, I'm not promoting a band, but PAN is usually combined with something.
Sir, these are being combined with a prokinetic drugs, I believe.
Prokinetic, because you want to induce the motility of the esophagus so that whatever acid is refluxing gets emptied quickly, doesn't stay there for a long time to cause irritation of the mucosa. So it is usually a combination of, and PPI is one form of acid suppression. Best is to say acid suppression. Acid can be suppressed by H2 receptor antagonists also, although nobody uses them these days, but many gastroenterologists believe that they are equally good as PPIs. So acid suppression and prokinetics. So lifestyle, diet, and pharmacological treatment.
Pharmacological management.
Yeah. So when do you start thinking of surgery in GERD?
Surgical management comes into play once the patient, after trying the lifestyle, the pharmacological management is still having persistent symptoms which are severe affecting life of the patient, or if or if on the investigation it has been found, like especially when that there is a portion of the stomach which is more than 50% present now in the thorax after the due investigations that we had done, and the chances of patient going into complications like volvulus and going into and the chances of that we have to do for we might have to go for an emergency surgery are pretty more evident. So, and then the obstructive symptoms when the patient starts complaining of dysphagia and severe bouts of cough, especially the nocturnal acid eructations and aspiration causing chest X-ray changes. So that is the time that we should advise patient regarding the surgical management, sir.
So suppose there is a patient who, as long as he takes prokinetics and acid suppression, he is all right. But the moment he stops, he develops symptoms again. What would you advise?
Sir, I would advise him to go for then. I mean, if they are if it has been on a if he has on he's been on a long term already on a long term PPI plus prokinetic regimen, and if he's but if he's not able to continue it in view of long term side effects, then we should advise him for surgeries.
What are the recently known adverse effects of long-term PPI administration?
Sir,
10 years ago, we used to say you can continue to take it lifelong. Now, many gastroenterologists are cautious. It's the renal dysfunction. There are studies which have shown that very long use of PPIs can cause renal dysfunction, and that is why there is a rethinking on that, that even if the patient is well controlled on PPIs and prokinetics, it may not be correct to advise that, okay, you can continue to take them lifelong, especially if on stopping there is a recurrence of symptoms. But definitely failure of medical management to relieve symptoms is an indication, like in many other conditions. And then you mentioned complications. So you mentioned stricture.
yes.
Okay. Any other?
Sir,
And you mentioned about volvulus.
yes,
How do you suspect that this patient is likely to have volvulus? You said if the patient is likely to have volvulus, how do you know that? We can't hear you.
Sir, I'm not able to hear your question.
Any other student would like to come in? Manik, you are there. Can you answer? हमारा नहीं, उसकी आवाज नहीं आ रही है. You can hear us?
I can hear you, sir, right now.
Yes. Now we can hear you. Yes. So
yes.
How do you know that this patient will have volvulus?
Sir, if the patient is complaining of sudden onset of epigastric pain along with the bouts of
No. That is the manifestation of. You said that if the patient is likely to have volvulus, then I would advise surgery. Once the patient has developed volvulus, then obviously you have to. So how do you know that this patient is likely to have volvulus?
Sir, if on radiological investigation, if it is seen that more than 50% of the stomach has already migrated inside into the thorax, these kind of patients do in long term.
Yeah. So the first answer is that it is the paraesophageal hernia which predisposes to volvulus, not sliding hernia. Sliding hernia, there will be no volvulus.
No volvulus. Yes.
Okay. And second is that if the hernia is large, that means how much of stomach has gone into the chest. And if the defect is large, both the conditions, then the patient is likely to have gastric volvulus. Okay. And in fact, if it is a reasonable size paraesophageal hernia, especially in a young patient, then your threshold for offering surgery should be low. Because in paraesophageal hernia, as we discussed earlier, there may not be any esophagitis, there may not be any GERD symptoms, but like any other hernia, because it is a true hernia, it has the risk of getting obstructed, getting strangulated, having a volvulus. So most, unless it is very small, unless the patient is elderly, has comorbidities, most paraesophageal hernias, you should advise surgery like any other hernia. Okay. Okay, fine. So we have decided that the patient needs surgery. What
Yes.
is the procedure?
Sir, for hiatal hernia, we have options of going for open hiatal hernia repair surgeries as well as minimally invasive laparoscopic hiatal hernia surgeries. Uh, uh, Sir, and along with that, we in most of the cases we do go for anti-reflux surgery also, because as to avoid the GERD as a post-op complication.
So can you briefly describe what exactly is done?
Sir, the major steps being first is the reduction of the content. Uh, uh, once we are into the abdominal cavity, the first major step is reduction of the content, so as to define
What
the.
is the first step? What is the first step in any surgery for hiatus hernia? Technical step.
Sir, the first
Once you are in the, yeah.
Sir, the first step would be the I mean the positioning of the patient, sir. I mean that's what I want to ask.
How do you see the esophageal hiatus? Suppose you want to do vagotomy, you want to do HELLAS, you want to do hiatus hernia repair. What is the first step?
Retraction of the left lobe of the liver is the
So it is the division of the left triangular ligament so that you can retract the left lateral segment. Then only you will be able to see. Or sometimes if it is small and it is pliable, you can just lift it up.
lift it up.
Especially if you're doing a laparoscopic procedure using a Nathanson retractor, you can lift it up. But most people, especially if it is large, would like to divide the triangular ligament so that you can retract it softly and gently. Okay, then
Sir, then we start. Then we should. I mean, we should start reducing the contents, and the second the step next step would be to.
what do you mean? What do you mean by reducing the content? In which type of hiatus hernia there are contents, and in which type there are no contents?
Sir, type 1 hernia, that is the sliding hernia, will only have the migrated GE junction, and while in type 2 and type 3 and type 4 we will have the
So
contents.
reduction of contents is actually for.
Okay.
I lost connection. Yeah, sorry, we lost the connection temporarily. So what I was saying, that the term reduction of contents is actually for a paraesophageal hernia,
Yes.
because as we discussed, there is a defect through which contents have gone into the chest. In sliding hernia, it is only migration of the stomach. So for a paraesophageal hernia, you say reduction of contents. For a sliding hernia, you say mobilization of the intrathoracic part of the herniated stomach and the esophagus, and bringing the GE junction down below the esophageal hiatus into the abdominal cavity. And that is why you need to mobilize a certain length of the esophagus. And it is possible
Approximately.
unless there is shortening of esophagus because of long-standing inflammation. In most cases, you can bring the GE junction down into the abdomen. Okay, then so let's discuss about sliding hernia only. We have brought the GE junction down. Then what do you do?
Sir, then the division, then the dissection should be done on the in the near the phrenoesophageal ligaments, and trying preserving the peritoneum covering, and so that crural approximation can be done once the herniated part has been brought down into the intra-abdominal cavity. And
Yeah, so three important steps of repairing a sliding hiatus hernia are: number one, to bring the, of course, mobilization of the herniated stomach and lower intrathoracic esophagus, bringing the GE junction down into the abdominal cavity, getting a length of esophagus in the abdomen, about 2 centimeter or 3 centimeter, because that is important, because around that you will do the fundoplication. And then the repair of the crura to narrow the enlarged or dilated esophageal hiatus with a few interrupted sutures. So this is as far as repair of the hernia is concerned. And then you add what you rightly said, a anti-reflux procedure. Which anti-reflux procedure will you use?
Sir, we do a posterior partial fundoplication, that is toupee fundoplication that we do, or we also on a regular basis also go for Nissen's fundoplication. But going by the literature, they say that posterior partial fundoplication has been found to be associated with less complaints of post-operative dysphagia. So,
can you quickly define fundoplication?
Sir, it is the total Nissen total 360-degree fundoplication, that is known as the Nissen fundoplication, and then there is a partial posterior, which goes by the name toupee fundoplication. The anterior one goes by the name of DOR, and there is a Belsay Mark IV also.
So DOR is how much?
Sir, DOR is 180 anterior, and the
so
toupee
Nissen is complete 360. Toupee is posterior 270, which means only the anterior 1/4 of the esophagus is left bare, and DOR is only anterior 180. I don't think any group uses DOR as a fundoplication per se. Most people use DOR along with a Hellas cardiomyotomy, because DOR per se as a fundoplication may not be very effective. So people would use either Nissen or toupee. And Nissen, you should say, most people today would use what is known as would they use a classical Nissen, or what is the modification?
Sir, I'm not aware.
It's called floppy Nissen. Floppy Nissen means that although you have covered 360-degree, but between the fundal wrap and the esophagus, there is a space. At open, you can put a finger. At laparoscopy, you can put an instrument which should go easily. So there is some space so that it doesn't cause complete obstruction, resulting in complications in the post-operative period. So most people would use either a floppy Nissen or a posterior partial toupee fundoplication as the anti-reflux procedure. DOR is used mainly as an adjuvant to cardiomyotomy to cover the exposed esophageal mucosa. It probably, at least in my opinion, and because nobody uses this anti-reflux procedure alone, it is probably not a true anti-reflux procedure, although it is described as an anti-reflux procedure. Okay?
Yes, sir.
Okay, good. Thank you. So all students, if you want to read more about reflux esophagitis, I think earlier I have sent the chapter on esophagus, which does include this. But if you want it again, send me a mail, vkkapoor.india@gmail.com. Write esophagus in the subject of the email. Okay. Thank you. Thank you, Himanshu. Thank you.
Thank you, sir. Thank you for your patience. Have a great day.